So he is a
Yes, sir.
50-year-old person with known history of chronic alcoholism leading to alcohol-induced cirrhosis of the liver. He has got a umbilical hernia. So how to manage the anesthesia and perform the surgery in this patient is the question. So let us see what Dr. Sivathanu is going to tell us about this. You can start, Siva.
Yes, sir. Yes, sir. Good evening, sir. So chief complaints to start with. It's a 50-year-old patient who is suffering from alcoholic cirrhosis of liver, post-refer umbilical hernia repair. The history of presenting illness. First, I will go with the umbilical hernia history, the history of onset and the duration of hernia, and the location and the character of swelling, and the history of reducibility, and the cough inverse, and whether it is associated with pain or not, and it's a bowel and bladder habits. And then there is a history of alcoholic cirrhosis, onset and the duration, and then the history of the symptoms of liver decompensation as well as that history of yellowish discoloration of skin or sclera, and the history of swelling abdomen or abdominal distension, and the history of any sleep disturbances and our behavior changes, and the history of bleeding, and I will ask the history of the systemic complications of the cirrhosis, like the history of exercise intolerance, or a history of any shortness of breath at rest, and the history of orthopnea, paroxysmal nocturnal dyspnea, and the history of peripheral edema, but cirrhotic cardiomyopathy, and any associated history of chest pain, or the palpitation, or syncope for any associated CAD, and then also a history of dyspnea on exertion, or platypnea, or orthodoxia, and to rule out pulmonary pulmonary syndrome, and then the history of any reduced urine output, and the history of any hematuria, or a history of any recent infection to rule out the renal involvement, and then I last about the history of any weight loss and appetite and dietary intake to also a history of malnutrition, and then I last a history of confusion or any memory problems to rule out any electronic disturbances, particularly hyponatremia, and any history of any EC and the history of any hematemesis or melena, and the history of any red spots on the skin to rule out the coagulopathy, and past medical history. So any history of any previous hospitalization, especially for any GA bleeding or hepatic encephalopathy in the past, and any past history of diabetic mellitus, hypertension, CAD, COPD, and seizures, and any history of previous blood transfusions or viral hepatitis, and any history of any previous surgeries and anesthesia exposure, and especially history of any halogen exposure in the past, and medication history. We have to review the current medications. The patient is on diuretics, furosemide and spironolactones, and the patient history of any lactulose or reformation intake, and any history of any intake of any beta blockers, and any proton pump inhibitors or H2 blockers, and finally we have to ask about the history of snoring, and a personal history. It's an alcohol history, the intake and the quantity and the duration, and the smoking history, and coming for general examination. First, I look for general appearance of the patient, nutritional status, look for any muscle wasting, and orientation, and interest, pallor, clumping, and cyanosis, and they look for liver cell failure signs, the spider navy, and palmar erythema, leukonekia, restoration of skills, and peripheral gland enlargement in gingival bleeding, gynecomastia, and it's a pedal edema, and generally lymphadenopathy. And then check about height, weight, and general BMI status of the patient. And vital signs, heart rate, BP, SpO2, respiratory rate and temperature, along with the pulse pressure due to the hyperdynamic circulation. And the systemic examination, first general cardiovascular system, it's look for any elevated JVP, and heart sounds, and any look for murmur, and any respiratory system, or the bilateral chest movements equal on both sides, and any usage of any accessory respiratory muscles. And in abdominal examination, the expression is abdominal distension present, and dilated veins and capital medicine, and the umbilical hernia examination, size reducible or not, skin over hernia normal or not, and the cough impulse present or not, and the palpation, the tenderness if it is present or not, and if any guarding associated with rigidity, and in liver palpation, and any spleen enlargement, liver, and the percussion, septic dullness, and the liver span, and abdominal grip, and auscultation, look for bowel sounds. And in central nervous system examination, look for any flapping tremor. And the routine airway examination, and then go to investigations. It's a complete look for hemoglobin, and the glottal count. If elevated, it's a goes any infection person, and then the look for platelet, and RFT, urea creatinine, and estimated glomerular filtration rate. And in LFT, the serum bilirubin, STOT and STPT, and the serum albumin, and then coagulation, the coagulation markers, the prothrombin type, INR, and the APPT, blood glucose, electrolytes, especially sodium, potassium, and the viral markers, and then ECG changes in the inactivity, prolongation, or in ventricular growth and ECG depression, and then in echo to look for any systolic and diastolic dysfunctions, and chest X-ray and look for any total attention or basal athletics or any cardiomegaly, and then ABG to look for any metabolic alkalosis or PaO2 level, and if needed, there's a angioscopy to assess various sites and the risk of any repeating due to surgery. And then I will satisfy the patient based on the Sivathanu score or MELD NA score. Based on the score, I will optimize in case of Sivathanu score. If the score is class A, with 5 to 6, can undergo elective surgery safely. But if it is 7 to 9, we have to elective surgery after optimization. And if it more than 9, 10 to 15, the elective surgery is contraindicated. And optimization, and then we have to assess the patient-specific risk factors, any comorbidities and all the effects of cirrhosis and organ system, and then the surgical risk factor, any abdominal surgery, any emergency surgeries, or any open abdominal or intra-abdominal surgeries, and any recurrent surgeries. We have to assess, and we have to optimize the patient before proceeding with surgery. Optimization in hepatic encephalopathy, we have to give the lactulose or rifaximin to reduce the ammonia levels, and in ascites, we have to resist salt intake, and the diuretics to be added. Spinal letter of summit, and paracentesis if ascites is present or interfering with the ventilation or any surgical access difficult, and consider albumin if infusion after large volume of paracentesis, or in case of any coagulopathy, vitamin K 10 mg slow IV for 3 days. If still prothrombin time is high, FFP to be confused, and in case of increased creatinine, correct all the precipitating factors, and IV place 12 hours before the surgery, 1 to 2 ml per kg per hour, and electrolyte imbalance to be corrected. In case of severe portal hypertension, then tips to be performed before surgery. Anemia, in case of blood transfusion if symptomatic, and in case of varicose feeding, beta blockers and endoscopic binding as needed, and infection prophylaxis to prevent SPP. And in case of fibrinogen level less than 100 milligram per deciliter, cryopressure to be given. The tolerant fibrinogen level should be more than 100 milligram per deciliter, and nutrition support if malnourished. And intraoperative goals, we have to maintain the hepatic blood flow, maintain oxygenation, adequate optimal fluid volume, avoid hypoxia, hypercapnia, and antibiotics to be given, and detect and point of care coagulation, detect and rotem for monitor coagulation, and antifibrinolytics. Intraoperative management is a general anesthesia with an intraoperative intubation. It's a personal monitor, standard ASA monitors, plus invasive outline, and this invasive outline that's 3 days before induction, and neuromuscular monitoring essential for titrating muscle relaxants due to altered pharmacokinetics, and is a BIS or entropy for optimal anesthesia, and IVSs to large bore IVSs, and there's a pre-medication. It's a lorazepam is the safest as we have no active metabolic but avoid or use minimum sedation due to increased sensitivity or risk of worsening hepatic incapability with benzodiazepines. Glycopyrrolate if I suspect significant secretions or bradycardia. And pre-oxidation at 100% O2 for 5 minutes. And injection is a rapid sequence injection due to increased aspiration risk. And drug of choice is a propofol 1 to 2 mg per kg, but best to titrate according to the response. And relaxing succinyl scoring 1 to 1.5 mg per kg. If Sugammadex is available, go to Dropronine 0.9 to 1.2 mg per kg. And opiates for nemicontrolled in choice of analgesia, and if not responding, continue 1 to 2 mg per kg. And maintenance before intubation, you have to register as a sympathetic nervous system response because under maintenance maintenance with sevoflurane and isoflurane. And the fluid management, maintain the euvolemia, don't overload underload the fluids, and allowing to maintain the osmotic pressure. The temperature to be maintained by maintaining normothermia and warm IV fluids, and glucose to be checked frequently for every 2 hours. And the intraoperative NSL-16 infusions, and the extubation, full reversal of neuromuscular blocking agent, and the patient must be fully awake, hemodynamically stable, normothermic, and have adequate respiratory effort. And in post-operative, we have to continuously monitoring the patient, and the assist with input-output shot, and frequent assessment of neurological status, temperature, and all the LFT and the RFT electrolyte series to be repeated. And for pain, it's a multimodal anesthesia, it's a tab block, and local infiltration, and opiates, paracetamol and NSAIDs to be avoided. And for DVT, that's a mechanical prophylaxis, and nutrition to be added. These are diuretics once a hemodynamically stable. And then the regional anesthesia, in case of regional anesthesia, there's in case of the coagulation parameters normal, you can go to the spinal anesthesia, the single spinal anesthesia. Thank you, sir.
So your first choice is general anesthesia for this surgery, is it?
Yes, sir.
The only last option is central neuraxial blockade. Finally, supposing it is a very small hernia with no major contents inside the sac, what are the other options?
Then we can put a single spinal anesthesia, sir. We will better hemodynamic control.
Have you ever seen an umbilical hernia being operated under local infiltration anesthesia? Very small umbilical hernia. Have you ever seen a plastic surgeon or a general surgeon doing a very minimal small umbilical hernia under local infiltration anesthesia or rectus sheath block? Have you ever seen it being done like that?
No, sir.
Not seen.
Yes,
right. Soundarya, do you agree with what Sivathanu says? All this. What is your option? Supposing you have a patient with cirrhosis of liver with a very small umbilical hernia, what anesthesia you will give?
We can go for a nerve blocks, sir.
Nerve block.
Rectus sheath nerve blocks.
Rectus sheath. There is no nerve block there. It's called rectus sheath block.
Facial blade block. Yes, sir.
Okay. Or even local infiltration and then using the sac and
local infiltration we can give, sir.
That is also one of the chances available. But anyway,
I just saw yesterday an inguinal hernia being operated by Dr. Major Rangan sir under local infiltration and just monitored MAC sir, monitored anesthesia.
Yes. It's a very, very easy procedure because it's a superficial thing. If you are a gentle surgeon, you can definitely do it under local infiltration in a very high risk patient. There is no need to all the time give
He also explained the
final or
procedure that he could see,
Pardon?
visualize everything. And he also said that he could visualize everything, and under vision he can locally infiltrate wherever he needed the anesthesia, sir. So
yeah,
we
that
just
is surgeon's way of
completed
doing it.
procedure.
But anesthetist, we can give a nice what is called the inguinal hernia block. There is a
Block.
technique which we used to practice in those days very regularly in a patient. But you need a very good selection of your patient. You can't do it in all fussy patients or obese patients. It will not be very easy. So you have to block the ilioinguinal and iliohypogastric nerves properly, and then at around the sac you should all these things, unless the surgeon also knows the technique of infiltration, he cannot do it under local. So for the first time, okay? There have been surgeons who have been doing hernia without a major content like bowel or omentum, and nicely reducible hernias have been done under local by the senior surgeons routinely. Okay? But many of the younger present day surgeons may not know that technique. Okay, that apart, now whenever you get a case of liver, whether it is cirrhosis or obstructive jaundice, there are a certain pattern of questions that are likely to be asked in your examination. Okay? Right, starting from the anatomy of the liver to the physiological function